eyes and how to read, and how to read the wavefront map. Okay, types of aberrations. There are two types of aberrations: the lower order aberrations, which are associated with the myopia, hypermetropia, or astigmatism, and the higher order aberrations, which they consist mainly from spherical, coma, and trefoil, and the other aberrations are derivatives of these three main categories. Great. We have to know that 98.2% of the higher order aberrations arise from the anterior corneal surface. So the anterior corneal surface is the main source of high order aberrations, not the lens and not the posterior corneal surface. The posterior corneal surface and the lens, they have compensatory role to compensate for the high order aberrations arising from the anterior corneal surface. This is very important to know. Now, what is defocus, which is part of lower order aberrations? It is a lower order aberration that occurs when the image is either in front of the retina in myopia or virtually back to the retina in hypermetropia. So we call this defocus. And it causes blur of vision, which increases with the pupil size, has a relation with the pupil size. There is another lower order aberration known as the astigmatic. Of course, it occurs because of the astigmatism, as you see. All right. Now, there are two types of astigmatism: the vertical astigmatism and the horizontal astigmatism. The vertical astigmatism occurs, or let's say the vertical astigmatism causes horizontal defocus. Here it should be defocus. No, sorry. Yeah, horizontal focus, but vertical defocus. Yeah, it is correct. So the vertical astigmatism causes defocus in the vertical direction, as you see, while the horizontal astigmatism causes a defocus in the horizontal direction, but there is a vertical focus. Of course, for the lower order aberrations, the treatment can be glasses, contact lenses, and this is contrary to the higher order aberrations, which cannot be corrected by the glasses and contact lenses. Now we come to the higher order aberrations. We need to talk about the spherical aberration because this is the main issue related to the depth of focus, related to the contrast sensitivity, related to the quality of vision, and related to which type of IOL is best. Now, the spherical aberration occurs when the refraction is not equal along the refractive surface, but it is rotationally symmetric. All right. So, for example, this is, I think this is positive. Yes, this is the positive spherical aberration. We see that the periphery of the refractive surface refracts the incident rays in an angle which is larger than those in the paraaxial rays, and vice versa for the negative. So we can say that there is positive and negative spherical aberrations, and this is very important as well to put it in mind when we are going to talk about the depth of focus. Of course, spherical aberration appears as halos around the spotlight. There are four representatives to, let's say, corneal asphericity: the Q value, P value, E value, and eccentricity. But the most famous one and used one is the Q value because it reflects the shape of the cornea. Accordingly, we can say that the cornea can take one of these shapes. Okay? What are these shapes? When Q value is 0, as you see here, the cornea is a sphere, a part of a sphere. And the patient will suffer from higher order aberrations. And when the Q value is positive, the cornea takes the shape of an oblate shape. Okay, it is oblate, which means that in the center it is flatter than the periphery, and it causes positive spherical aberration. Now let's go to the negative side, which is below 0. We have 1, 2, 3, 4 types of shapes, as you see. Let's start with the parabola. You see the parabola? You see the Q value is minus 0.53. This is the perfect shape, which does not generate any spherical aberration. So if my Q value is approximate to minus 0.53, it means that I'm not suffering from any spherical aberration, which is a disadvantage in human. Now, before the parabola, in the positive side, we call this positive prolate, and it causes positive spherical aberration. And after the parabola, the two shapes generate negative spherical aberration. They are the negative prolate and the hyperprolate. You don't need to memorize all of these things. Just you have to remember the number of minus 0.53 at which there is no spherical aberration. All right? Just put it in mind. Accordingly, we can come to this beautiful slide. Now, this beautiful slide shows us the correspondence between the shape of the cornea, Q value, and the generated spherical aberration. When the Q value is minus 0.53, there is no spherical aberration. More positive than minus 0.53, there is positive spherical aberration, and vice versa. However, the spherical aberration, either positive or negative, can be classified into 3 categories. The normal one, or let's say the usual one, let's say it is the usual one, which is below plus 0.35 or below minus 0.35, okay? And the non-toxic up to 0.6 in both directions, and the toxic, which is above 0.6 in both directions, all right? Please put this in mind because it has a correspondence to the depth of focus and contrast sensitivity. Now, where is the human cornea? The human cornea is in the positive direction. The spherical aberration generated by the human cornea is plus 0.27 microns plus minus 0.1. All right, so it is in the positive direction. And usually the normal range is up to 0.55, okay, plus 0.55. All right. Now, we have to know that contrast sensitivity, which represents the quality of vision, is at its maximum. It is ideal, it is very good when there is no spherical aberration. Then it decreases and deteriorates with the increase of spherical aberration in both directions. In addition, there is a concept called the depth of focus, which I'm going to talk about it in a minute. You have to put in mind that the depth of focus, there is no depth of focus if there is no spherical aberration. And depth of focus will increase gradually with the increase of spherical aberration in both directions up to toxic. Whenever the spherical aberration goes into toxic, then almost there will be no depth of focus. Great. what will happen to the cornea when we do the laser-based refractive surgery? If we apply the myopic treatment, then it will be more positive. And if we apply the hyperopic treatment, it will be shifted towards the negative side. What is the depth of focus? Let's assume that this gentleman who is 70 years old and doesn't have accommodation and still can read the book with his glasses, of course, and he can bring the book forward and backward and still can see the letters clearly in spite of no accommodation. All right? We call this the depth of focus. So the depth of focus doesn't have anything to do with accommodation. All right? Now, yeah, I want you to see this slide. As you see, when there is no spherical aberration, the letter, let's say the image of the letter on the retina is very clear, and it is transferred to the neural, to the brain, and the brain will see it very clear. Now, what if this letter goes backward or forward? It will be blurred on the retina and it will be affected in the brain. Why? Because there is no spherical aberration. Now let's see what will happen if we have spherical aberration. This patient has some spherical aberration, although the image in the retina is a little bit blurred, but still the brain can see it because the spherical aberration is still in the non-toxic range. And if the letter comes forward or backward, okay, it is still clear in the brain because it is within the range of the depth of focus. All right? Now let's see what, of course, if it is out of the range of the depth of focus, it will be blurred. Now, what if the depth of focus, the spherical aberration increases and starts to go into the toxic range? In this case, the image in the brain will start being blurred. Okay, great. Okay, good. Now we come to the coma. The coma, of course, is generated by corneal irregularities, such as decentered optical zones, irregular cornea, scars after keratoplasty, for any reason. And there is another type, which is lenticular, like subluxation, zonulopathy, IOL decentration, and so on. And of course, people suffering from coma, they will see this tailed images. Sorry. What is the trefoil? The trefoil occurs when the periphery is affected. In the coma, the center is affected. Here, the periphery, and it will show the sign of a trefoil or Mercedes-Benz sign. This is why it is taken, the trefoil is taken from this plant, which is trifolium. And patients with trefoil will see star bursts, as you see. While people with coma, they will see shadows and ghost images. Now, how our body compensates for the aberrations? We know that the main source of higher order aberrations is the anterior corneal surface. Other mechanisms that compensate for this is the posterior corneal surface, the crystalline lens, the retina itself, and the brain. Okay. For the crystalline lens, I'll give you an example about the spherical aberration being compensated by the human crystalline lens. If the human cornea is in the positive side, the human crystalline lens is in the negative side. So the sum will be almost 0 to plus 0.1 microns at age of 19 years. All right? And by age, the spherical aberration will go towards positive, ocular spherical aberration will go towards positive, not because the human cornea has changed, but because the human crystalline lens is going towards the positive. Okay? In general, there is internal high-order aberrations compensating the corneal high-order aberrations in order to reduce or minimize the ocular aberrations to the minimum that can be adapted by neural adaptation. So everybody of us has native higher order aberrations that can be compensated by neural adaptation. What is the role of the retina? Actually, the retina, our retina is not a concave, symmetric concave, because it should compensate for the tilt in the cornea. Our cornea is flatter in the nasal and steeper in the temporal, and it takes an ellipsoid base. In addition to that, it is aspheric. So all of this is being compensated by the tilt in the retina as well. And finally, the neural adaptation. Okay. Of course, when we are talking about what is the best IOL for my eye, it means that I'm going to remove the lens. Therefore, there will be a major change in the compensation, and the corneal high-order aberrations will not be compensated. And we have to compensate that by the IOL. Great. How to study the wavefront in order to start the roadmap? If we are going to study a map, first of all, we have to be sure that we are studying both surfaces together, not the anterior surface, not the posterior surface alone. In addition, we should use the 6 millimeter. We should study the central 6 millimeter of the cornea. After that, we click all off. We don't want to see any of these aberrations, and we have to select only 5 high-order aberrations. Only 5. Don't study everything. So whenever you see this map, be sure that only these 5 high-order aberrations are clicked. The third row, which is vertical trefoil, vertical comma, horizontal comma, and horizontal trefoil, and only the middle one in the fourth line, which is the spherical aberration. Now, if you look at this number, it shows the RMS of these 5, the selected 5. So this is the RMS. And, and the number below, it is Z40. If you look down RMS, you will see Z40, which is the spherical aberration given in Zernicke coefficient. It shows the amount of the spherical aberration with a sign. If there is no sign, it is positive, and if there is negative, it will show you that this is negative spherical aberration. Okay? And if you are using the Galilei, that was the pentacam, if you are using the Galilei, be sure that this is the 6 millimeter, and be sure that you are checking both surfaces, and you are clicking only these 5 high-order aberrations. If you are using the Cyrus and the MS39, you will find these categories: the higher order aberrations up, then the astigmatic top left. We don't want it because this is lower order aberration. Next to that, you will find comma, spherical aberration, and the residual. The residual mainly is the trefoil. Okay. Now, what is the normal range of high order aberrations at 6 millimeter? Because we need to know the cutoff values in order to be able to say this is normal or this is abnormal. Unfortunately, there are no cutoff values, no agreement. And the cutoff values are affected by age, ocular surface, dry eye, and accommodation. It is affected by population, measuring devices, and the study design. However, there is a general agreement, before that, and to show you the wide range of differences between studies, look at this study showing that the normal range of comma is up to 0.74 microns, which is very high. And the spherical aberration is up to 0.57, and the total aberrations is up to 0.8. This is the normal range according to this study. So it's very important to depend on studies related to your population before studying the maps. But in general, there is a general agreement. If you are using the Pentacam and Galilei, the RMS should be less than 0.35, less or equal to 0.35 microns. It is suspected if it is between 0.35 to 0.5, and abnormal if it is more than 0.5. And if you are, and if you are using the Cyrus and the MS39, you can go up to 0.5, then between 0.5 and 0.70, or above 0.70. Now, let's go. That was just like the appetizers, and now the main course, the types of the IOLs, monofocal and premium. The monofocal are spheric and aspheric. The old spheric IOLs generate positive spherical aberration of 0.15 or 14 microns. Okay, keep it in mind that when the era of aspheric lenses, then the companies started saying, don't use the old spheric IOLs. Let's compensate for the spherical aberration of the cornea. It will give sharper vision. That's not true. We shouldn't do this. We have to check other things before doing that. So the old spheric IOL still have a role. The aspheric IOLs are of three types based on the amount of spherical aberration that they generate. Zero spherical aberration, or the neutral one, doesn't generate any spherical aberration. Negative spherical aberration generating minus 0.20 microns, and negative spherical aberration generating minus 0.27 microns. Premium IOLs are of two types, trifocal and EDOF. This is what we are going to talk, inshallah, in the part 2. So if this patient comes to you and has cataract, and this is his cornea, which lens are you going to implant for him? Are you going to implant premium IOL? Okay, which premium IOL? Or maybe not, I'm going to implant monofocal. Okay, which monofocal? So as you see, the wavefront is an essential part in the workup for cataract surgery. We are not talking about tomography, which is an essential part as well, but we are talking about wavefront. Great. This is another case with different numbers. Which type are you going to implant? Great. So to know which type of these, I'm going to show you my PSIS algorithm. The practical subjective IOL selection, it depends on the amount and type of corneal high order aberrations. It depends on patient's demand, reading versus quality of vision. You remember we said that depth of focus increases with spherical aberration. There is a proportional relationship. Now, quality of vision goes down with more spherical aberration and with more depth of focus. So if the patient wants depth of focus, this will be on the account of quality of vision. If the patient is keen of quality of vision, type A personality like me, I am type A+++, then I care about quality of vision rather than reading or depth of focus, let's say. Okay. We have to know the pillars of the PSIS. First of all, premium IOLs are precious, which means that they do not accept to be implanted in eyes, not good quality eyes, not good quality corneas. They do not accept to be implanted with such eyes. Otherwise, if you insert a premium IOL in such eyes, it will make troubles to you and to the patient. Second, if the spherical aberration in the cornea is toxic, you have to push it towards non-toxic. Third, if the patient is interested in depth of focus on the account of quality of vision, okay, we have to maintain the non-toxic if he has the non-toxic. Or if the patient would like to have very sharp vision and doesn't care about the depth of focus, in this case, we have to push the spherical aberration that he has towards as close as to plus 0.1 microns, because this is the best that gives very sharp vision, which is the eyes of our children 19 years old. Good. Corneal high order aberrations. According to that, if corneal high order aberrations is normal or abnormal on the account of spherical aberration or abnormal on the account of other high order aberrations, then each one of them has its own path. Let me show you the first one. If the corneal high order aberrations are in the normal range, then of course, if depth of focus is critical to the patient, we have to go for the premium. Dr. Sommer, please disable the notation. Disable the notation for the audience. Otherwise, you will find people drawing on the slides.
Okay, I'll try to do that. Thank you, Dr. Mazin.
Yeah, pleasure. So if the patient is interested in depth of focus, then of course premium. Or let's say in reading, in addition to distance, then premium. But remember, this will be on account of quality of vision, contrast sensitivity. Don't believe that there is a premium IOL that does not affect quality of vision, does not affect contrast sensitivity. Don't believe that. Image quality is critical to the patient. In this case, because it is positive, the corneal aberration is positive, we have to negate it by negative spherical aberration, or maybe to maintain it just by the neutral spherical aberration in order to achieve the target. And these are examples. Pre-op corneal plus 0.35, we implant the minus 0.27 in order to achieve the post-op ocular spherical aberration almost near the 0.1. If it is before 0.20, we negate it by minus 0.20 in order to achieve the 0. Plus 0.12, okay, we maintain it by the neutral one. So this is the way of thinking. Now we come to abnormal, but on the account of other, not the spherical aberration, other high order aberrations like the trefoil and comma. In this case, if depth of focus is critical to the patient, EDOF is forgiving. Don't go for the premium, for the trifocal. EDOF can be put to some extent, and this is what we are going to talk about, inshallah, in the part 2. If image quality is critical to the patient, don't play with the high order aberrations. Just implant a 0 spherical aberration or neutral aspheric IOL. All right? Now, if it is abnormal, but on the account of spherical aberration, of course, either the eye is virgin eye, no operation before, but this is very, very rare, or maybe previously myopic laser vision correction or hyperopic vision correction. In the post-hyperopic laser vision correction, the spherical aberration is minus. Post-myopic, it is plus. Okay, pre or hyperopic. Of course, many cases are in the toxic range. In this case, we have to put the old spheric IOL, which generates positive spherical aberration in order to negate it. Okay, you see, still those old lenses are helpful. If it is in the non-toxic range, then we can think in the same way. depth of focus is critical, 0 spherical aberration or IDOS. If the image quality is critical, we have to implant the positive because we have to reduce the negative spherical aberration. Prior myopic laser vision correction. If it is non-toxic, depth of focus is critical, we keep it by the 0 or we enhance it by the IDOF. If the image quality is critical to the patient, we put negative spherical aberration because it is positive and we have to negate it. And if it is toxic, of course, we have to push it towards the non-toxic. These are examples. If we want to negate it, for example, pre-op, pre-cataract, I mean, this is post-hyperopic, post-myopic, the patient has plus 0.60, we have to implant the minus 0.27 in order to reduce it as much as possible. And for the other examples. And if it is toxic, we have to negate it and push it towards the non-toxic positive spherical aberration. Okay, and these are some examples. Okay, so we come back to these cases. This is case number 1. The total is 0.34 microns, which is normal, and the spherical aberration is 0.31, which is good one, positive one. So the total is on the account of the spherical aberration, but all are normal. So the patient has, because it is in this range, as you see the arrow, so this patient has, we expect that he has, let's say, fairly good or fair contrast sensitivity or quality of vision, and fair depth of focus. Okay. Now, if the patient wants depth of focus, premium IOL, because it is normal. Otherwise, we negate it by implanting minus 0.20 in order to push it as close as to the plus 0.1. And in this case, post-operatively, the patient will be very near to the 0 spherical aberration, and he will have very good contrast sensitivity, but very bad depth of focus.